Hello, my name is Daphne Worrell, Marketing Manager for ODG by MCG, and I'm excited to welcome you to today's webinar offering training on the ODG treatment guidelines and drug formulary for the state of Arizona. We'll have two presenters on this call, Jacqueline Kurth, Manager of the Medical Resource Office at the Industrial Commission of Arizona, and Jamie LaPaglia, Implementation Specialist and Clinical Educator for ODG. Before I introduce them, I'm going to go over some quick administrative details. First, I want you to know that this webinar is being recorded and the recording will be sent to you within 1 week. I've listed the dial-in information on this slide in case you'd rather not use your computer audio, and I'll also broadcast that dial-in information through the chat box a couple times throughout the presentation. If you're having trouble seeing the webinar, try using the Chrome browser rather than Internet Explorer. All participants are in a listen-only mode, so if you have a question, please type it into the chat box at the lower corner of your screen. We'll save some time at the end for questions, and any questions that we don't get to will be answered through email following the webinar. Now I would like to introduce our presenters. The first presenter will be Jacqueline Kurth, Manager of the Medical Resource Office at the Industrial Commission of Arizona. Ms. Kurth holds a Bachelor of Science degree in Speech Pathology and Audiology with a minor degree in Neuroanatomy from Colorado State University. She earned a master's degree in rehabilitation counseling from the University of Northern Colorado and holds national certifications in rehabilitation counseling, medical case management, and is a certified life care planner. Ms. Kurth has worked with medical providers, attorneys, risk management, and claims professionals for over 25 years in Arizona. Our second presenter will be ODG by MCG's Implementation Specialist and Clinical Educator, Jamie LaPaglia. Registered nurse and industry veteran Jamie LaPaglia has close to 20 years of nursing experience, including over a decade of managed care and claims management experience, working with some of the largest workers' comp and disability carriers and TPAs. He has held roles in utilization management, case management, analytics, and various leadership positions. This wide breadth of experience allows Jamie the ability to understand what users are experiencing and how they use the solutions provided by ODG. It also helps in working with payers and providers, as his experience allows him to bridge the gap and help all stakeholders understand how they can work collaboratively and maximize the solutions provided by ODG. So we'll get started with Jacqueline. Jacqueline, you can take it from here.
Oh, hello, and thank you for attending our webinar today. In order to keep this webinar to 1 hour and to give Jamie plenty of time to demonstrate how to use ODG by MCG, I will be giving a brief overview of Arizona's rules for the use of treatment guidelines. I would encourage everyone listening to this for more detailed information to visit our website. And with that, I will change the slide. This is the Industrial Commission homepage on the website, which can be found at azica.gov. Once you are on the ICA homepage, you can either use the Division tab to select the Medical Resource Office, or you can simply click on the Medical Providers icon, the one with the Saguaro cactus, to reach the Medical Resource Office webpage. I've got to try to remember to change the slides as well. Okay, this is the Medical Resource Office webpage, which has links to the treatment guidelines, frequently asked questions, flow charts for the pre-authorization, reconsideration, and administrative peer review processes, the ODG Appendix A drug formulary, a link to the MRO portal, the medical treatment pre-authorization form, and Article 13, the rules for treatment guidelines. As Daphne had mentioned, this webinar will be recorded, and a link to the recorded webinar will eventually be posted on the MRO and ODG websites. You can reach the Medical Resource Office at the Industrial Commission if you need assistance with anything related to the treatment guidelines, or have questions at mro@az.gov, azica.gov. Sorry about that. Okay, the rules. The rules for the use of the Official Disability Guidelines, or ODG, went into effect on October 1st, 2016 for the management of chronic pain and the use of opioids for all stages of pain management. The Industrial Commission also adopted Appendix A, the drug formulary, at the same time. In June 2018, the Industrial Commission amended the rules for the use of the treatment guidelines. As of October 1, 2018, the treatment guideline rules apply to all body parts and conditions for Arizona workers' compensation claims. The scope of Article 13, as previously mentioned, the treatment guidelines now apply to all body parts and conditions, as does the drug formulary, as of October 1, 2018. The rules only apply to medical treatment and services that have been, and conditions that have been accepted as compensable. The guidelines are to be used as a tool to support clinical decision-making and quality healthcare delivery to injured workers. The guidelines set forth care that is generally considered reasonable and are presumed correct if the guidelines provide recommendations related to the requested treatment or service. This is a rebuttable presumption, and reasonable medical care may include deviations from the guidelines. To support a request to deviate from the guidelines, the medical provider must produce documentation and justification that demonstrates by a preponderance of credible medical evidence a medical basis for departing the guidelines. In Arizona, under the Arizona Workers' Compensation Act, pre-authorization for reasonably necessary medical treatment is not required at the time of injury and during the period of disability. While pre-authorization is not required, a medical provider may seek pre-authorization using the Medical Treatment Pre-Authorization Form. The Industrial Commission added the Medical Treatment Pre-Authorization Form to Rule 20-5-106A Commission Forms. This form shall be used by medical providers and payers during the pre-authorization, reconsideration, and administrative peer review processes. A medical provider seeking pre-authorization for medical treatment or services should be using this form to submit their request, and payers should be using this form to communicate their decision on pre-authorization request. And this is the form. The Medical Treatment Pre-Authorization Form is downloadable and fillable and may be found on the ICA website under Online Forms and on the MRO website. Medical provider sections are in red and the payer sections are in purple. We have very detailed instructions, as you can see, for each section of the form. So I would encourage you to familiarize yourself with each step of the form. And we have detailed instructions on when you use this form, how to use this form, who uses this form, and where to file this form. Our goal was to make pre-authorization, reconsideration, and request for administrative peer review processes more efficient by having one form for all three processes and for medical providers and payers to use the same form. Okay, Section 1, it's red. This is the section for the medical provider. Medical providers are to complete the data fields on this section when asking for pre-authorization, and medical providers should indicate, to make sure they indicate their preferred method of contact. These two rules are very important for the payers that may be on this webinar, listening to this webinar. Rule 20-5-1304A and B. A payer shall not deny a request for pre-authorization solely because the guidelines do not address the requested treatment or services. And a payer is required to have medical or psychological reason not to approve treatment or services supported by the guidelines. Section 2, the purple section, of course, is for the payers, and this is where you fill out the information regarding your decision on the medical provider pre-authorization. You must fill out this section here and communicate your decision to the medical provider within 7 business days from receiving the pre-authorization request. You can approve, partially deny, deny in whole, or you can inform the medical provider the request is incomplete and you require additional information in order to make a decision, or you can indicate that you are going to get an independent medical examination or IME. If the form is incomplete, you should let the medical provider know they need to submit additional information in order for you to make a decision. A payer needs to communicate the decision to get an IME within 7 business days from receiving the pre-auth request. Once the final IME report is received, the payer must communicate its decision on the pre-auth request within 7 business days from receiving the request. A copy of the final IME report must be provided to the medical provider. And again, as I said, in June last summer, the rules were amended because now they apply to all body parts and conditions, and we changed the dates required for payers to communicate their decision from 10 days to 7 days. So remember, payers must communicate on the decision within 7 business days, and if a payer denies a medical treatment request that is supported by the guidelines, they must attach medical or psychological documentation to support their decision. Payer no response. A medical provider can come directly to the Industrial Commission and request an administrative peer review if they do not receive a response to the request for pre-authorization within 7 business days. And I have to say, we oftentimes see a number of administrative peer review requests because the payers have not responded to the request. The IME, you may decide to get an IME, but again, you have to communicate this decision to get an IME within 7 business days of receiving the pre-auth request. Once you get that final IME report, the clock starts again, and you need to communicate your decision on the pre-auth request within 7 days of receiving the final IME report. And you also have to submit a copy of that report to the provider. Payer denial of a payment for treatment or services that has already been provided. Again, it's similar to the last rules that applied to pre-auth, in that a payer is not to deny payment for medical treatment or services that have been provided solely because the guidelines do not address the requested treatment or services. Payers must have medical or psychological reason not to pay for treatment supported by the guidelines. The administrative peer review process through the Medical Resource Office addresses prospective or pre-authorization requests only, not retrospective payment disputes. Payment disputes for treatment that has already been provided is handled by the Administrative Law Judge Division. Again, I know I'm sounding a bit repetitive here, but the main takeaway is that payers need to respond to requests for pre-authorization and reconsideration within 7 business days. Section 3, red, this is for the medical providers, or perhaps an injured worker's attorney may want to fill out the reconsideration request. Generally, a medical provider must seek reconsideration of a payer's decision to deny medical treatment or services before requesting an administrative peer review. However, if a payer has denied a medical treatment request that is supported by the guidelines, or the payer does not communicate its pre-authorization decision within 7 business days of receiving the request, the medical provider may bypass the reconsideration process and immediately request an administrative peer review through the Industrial Commission. Again, just like with the pre-auth request, payers need to respond to any reconsideration request they may get from the medical provider or the injured worker or their attorney within 7 business days. Section 4, this is the payer section. It's purple. This is what you use to respond to a request for reconsideration. And, you know, at this point, you can still choose to get an IME after you receive a reconsideration request. But once again, you must communicate the decision to get an IME within 7 business days. And the same thing applies once you get that final IME report. You must communicate your decision within 7 business days of receiving the report and send a copy of the report to the medical provider. The administrative review by the commission. The administrative peer review process is handled through the Medical Resource Office at the Industrial Commission here. When we get a request for an administrative review, we go into our system, and of course, first thing we do is make sure that there's a valid accepted claim in our system. You can fax the request to, and I have the fax information on there, or better yet, if you are a medical provider or an injured worker's attorney, you can go into the MRO portal and submit the administrative peer review request directly through the portal. And Section 5, this is the section that is used by medical providers or injured workers or their attorneys to submit the request for the administrative peer review. Again, documentation of what medical treatment is being requested and the payer's decision should be submitted with the request for administrative peer review. Payers are not allowed to request administrative peer reviews. I get asked that question quite a bit. Okay, this is the portal. The MRO portal is really, really easy to use and very fast, and it's a great way for medical providers to just go in and upload their request for administrative peer review on their own, or the applicant attorneys or injured workers can use this as well. The role of the peer review vendors, it's very important we assign like specialists. So if we're receiving a request from a board-certified anesthesiologist, pain management specialist, we assign the peer review to that same type of specialist to perform the peer reviews. The peer review provider is required to make an effort to speak with the medical provider who is requesting the treatment. The process in its entirety typically takes 7 to 10 days. The peer review decision. We have created a standardized template for the peer review decisions, and the peer review decision is sent by the vendor to the medical provider, injured worker, their representative, the payer, and to us here at the ICA. The peer review decision tells whether or not the request for treatment or services is authorized or denied in whole or in part, and specifies the information reviewed and the principal reason for decision and the clinical basis and rationale for the decision. And how to dispute the peer review. Well, if any interested parties disagree with the peer review decision, they may request a hearing through the Administrative Law Judge Division within 10 business days after the peer review decision is issued. And that's all I have right now. So I am going to pass the baton off to Jamie so that he can actually show you how to use ODG by MCG to find information.
Thank you. Hi, everyone. This is Jamie LaPaglia from ODG. Thanks for taking some time out of your busy day to spend with us and review our system. Can everybody see my screen? Daphne, can you see the ODG by MCG website?
No, actually, I'm seeing the slide with Jackie on it.
Okay, hold on. Let's do that again. How about now? Probably the wrong screen, huh?
Yeah, it looks like your email.
I'm trying to, hold on guys real quick. How about now?
Got it.
Perfect. All right, so I'll work off the screen. So hi everybody, again, welcome. Sorry for that little bit of technical issue. Again, my name is Jamie DePalia, and really the goal today is give you a nice high-level overview of our ODG by MCG solutions here. It's really easy to access the website, as you'll see. For those of you who are familiar with our legacy site, I think you'll see that this one is much easier to navigate. The information is presented in a much more consumable manner. I think it's a lot easier to sort of use and incorporate into your daily workflows. So we'll go, for the purpose of this demonstration today, we're really going to focus on the treatment guidelines and on the formulary, because that's really the goal of today, is to really kind of educate you guys on how to use the ODG treatment guidelines in sort of determining medical necessity of various treatments. Please keep in mind that these treatment guidelines speak only to medical necessity. So our guidelines do not in any way, shape, or form speak to whether you should pay or not pay for any treatment. Again, it's strictly regarding the medical necessity of a given treatment. So that said, when I'm done with showing you the treatment and the formulary, I will briefly show you some of the other tools that we have just to give you an overview, because many of you, when you access some treatment guidelines, you will see those. But of course, if you do want, we could always do a more expanded training on those other solutions that we offer, such as the duration, the tau, the cost, and so forth. So with that being said, let's jump right into the treatment guidelines. The way it's set up is we group everything by sort of topics. So meaning you can search for an epidural steroid injection, a spinal fusion, whatever that treatment may be, you can search by just typing in the name of the treatment here in the search bar. Or you can use the CPT code. So we do allow you to search by ICD-9, ICD-10, CPT, and for those of you that are looking for medications, we do have the NDC, which is National Drug Code. So if you're looking for a particular medication, such as the formulary. So what I want to do for the first example for the treatment tab, before I go into that, just kind of give you an overview of the treatment tab itself. So again, this is where all the treatments are stored. And you'll see when I come into the treatment tab, I can search again by typing in a name of a treatment, let's say physical medicine. Simply type in my term, and it will do a search and show me all the different treatments that match that term. In this case, there's 38. You'll see some of them have a lot more results. For instance, say I was looking for something for the low back. You'll see that there's 642. The reason I did this is to kind of show you that there's this thing here on the right called the filters. The filters really help you narrow down your search results so you can work with something a little bit more manageable and not have to go scrolling through so many different results. So the way this filters work is we have 3 different types of filters. The first filter is by recommendation type. So you have recommended, not recommended, and under study. The second is by category. You can see the different categories we have here. And then lastly is by body system. And again, for those of you that may have seen the old legacy site, the ODG legacy site, you'll remember, recall that it was by chapters. This would be something similar to that chapter sort of logic, in that every treatment for this body system could be found by simply clicking on, say, low back. If I click on low back, that will give me all the results for low back. So with that being said, let's say that you, we'll do a couple of different scenarios. One being we don't know what a treatment is. We're just trying to see what a recommended treatment would be. So let's say we had someone with a neck injury. We were trying to determine the pain generator. So we probably want to do a diagnostic test or imaging test, right? So in the treatment tab, we'll simply come over here to where it says recommendation. We're going to change it to recommended. We'll change the category to diagnostic. And then we'll change the body system to neck and upper back. What that's going to do is now show me 13 results. These are the 13 recommended diagnostic studies for someone with a neck injury. So from here, we can kind of get an idea of where the next, if we're trying to create a treatment plan, we can identify the most appropriate next steps in doing so. Because these are the treatments that, again, are supported by evidence-based medicine. So with that being said, let's just take a pause real quick, because all this is predicated on the fact that these are supported by evidence-based guidelines. So, well, what is evidence-based guideline and how do we get them? And that's really important to know. So at the very top of the site here, you'll see where it says help and training. In that section right there under information and guides, there's a couple key pieces of information here. Now the first one I'm going to show you, I'll warn you, is probably not something you're going to want to look at often. It's 119 pages. It's very in-depth. So unless you're a little bit nerdy like myself and you like to look at these kind of things, it's good to, I guess, just know it's there though. So I'll go ahead and click on that methodology PDF here. What this does is it goes over from start to finish. This really is the foundation of what ODG does. So again, ODG is the worldwide leader in evidence-based guidelines. We're recognized internationally. We're in several different countries. And the reason for that is because there's such a rigorous methodology to what we do. At the end of the day, ODG doesn't create the guidelines per se. What we do, though, is we research, we go out there and pull all those studies out, all the random controlled trials, pull it all together, we synthesize it, we summarize it, we rank it, and then we provide it to you in a way that's really easy for you to use, sort of validate and move treatment forward, knowing using what's best for the patient. So again, this methodology paper here goes into great detail, and of course, I'm not going to go into it in depth today, but just to kind of show you all the different information you'll see here, how we rank against other guidelines, degree methodology. We actually have 2 PhD methodologists on staff. That's their role is to make sure that the studies we use are statistically significant, that we rank them appropriately, so that you guys can feel confident when you have make a determination, that the determination you make is based on sound medical evidence. So again, I'm not going to go into this. I just did want to show you something really quick in this slide, just to kind of show you the scope and breadth of what we do, how do we come up with what we come up with. And that's the slide that shows you how much we actually look at. So this is just for 1 year. It just kind of goes to show you how much research is actually put into the guidelines that we're using here. So we look at almost 300,000 abstracts every year. And of those 300,000 abstracts, we pull a little over 20,000 new articles, and from there create almost 8,000 new citations. So that just goes to show really the breadth of research that goes into our treatment guidelines. So again, when you're looking at a treatment guideline, and let's just pick any one of these for this one, CT, when it says recommended here, and it gives you this criteria, that it's not something, again, that ODG came up with. It's something that we sort of synthesize from all the extensive research that's out there that goes into supporting the recommendation and the criteria. So again, a lot of information. Again, we're not going to go into any further now, but just so you know that it's there if you want to learn a little bit more about how we do what we do. And then the other really important piece of information is, again, up in this help and training, under information and guides. There's this PT and Chiro guide insert, which is really great in understanding the conservative methodology, the idea of starting with more frequency, titrate down to less frequency, and eventually into a home-based exercise program. Making sure it's functional gains being made. The idea being, again, if ODG recommends, say, 20 sessions, we wouldn't recommend doing all 20 sessions for a shot. Instead, probably doing 10 to 12 at first, doing a reevaluation, making sure there's functional gains being made, and there's still some deficits that would benefit from additional therapy. And then if that's the case, going ahead and continue. And then, again, it's not to say we don't want people to have therapy, but what it is saying that if you have 10 sessions, you're not making any functional gains, well, then by doing additional sessions, we're not really expecting any benefit, and in fact, it's only going to likely cause a negative effect, because if you're having treatment that's not effective, not only are you not having a benefit from the treatment, but you're not having treatment that could be effective. So it's kind of delaying recovery, and we know all the things that go along with sort of delayed recovery, which is none of them are good. So that's the PT Chiro guide insert, and lastly is this documenting exception. And I'd like to tell people I'm not a chef. We're not in the cookbook business. We're not referees. We're not rule makers. Document exception goes to the fact that these are guidelines, which means they're good for most of the time, but not all the time. And at the end of the day, it's really up to the guideline to provide a framework to work within, but knowing that sometimes you may have a claimant that's outside the guideline, and that's okay. So document exceptions kind of tells you, how do you go outside the guidelines? What kind of information is needed? All the different stuff. Is we talk about supportive care a little bit in the presentation, and sort of more chronic type of conditions. Those all would come into these exceptions to guidelines. So if you view this, it gives you all different information on that kind of stuff. As you can see here, ongoing for chronic conditions, what if there is no guidelines for the condition. All this good stuff is really good to look at. Again, here, periodic worsening, this would go to supportive care. I've heard in the past people say, well, ODG doesn't really address supportive care. And it's sort of a misnomer. So supportive care really is about treating an exacerbation, right? Once a claimant reaches maximum medical improvement, we assume that there will be no additional benefit from additional treatment. They've basically reached plateau. and no additional treatment will be expected to produce any more curative or restorative benefit, right? So with that being said, that doesn't mean that 6 months down the road they don't have an exacerbation of low back pain and perhaps they need a short course of therapy to return them back to their baseline. So ODG does actually provide guidelines around those type of treatments in that context. Or maybe they have a foraminal radiculopathy, so they need an epidural steroid injection. And again, in a minute, I'll show you how to find all that information. So that's those guides and the information and guides. Very useful stuff if you're interested in looking at it. So going back to the guidelines now, knowing now how we come up with the guidelines, let's go ahead and look at a few guidelines. So I think one of the best ones to demonstrate, well, let's start with physical therapy because it seems to be, in our review of what the most used treatment guidelines are, physical therapy is consistently at the very top. So what I'll do is just sort of show you how to find physical therapy. This is our homepage here. You can see on the bottom right-hand corner here, on the bottom right side, there's a column here with medical treatments. These are the top 15 medical treatments that we see. So we put them here as a bit of a shortcut. So if you wanted to see a treatment guideline here, all you do is simply click on any one of these, and it will bring you to the treatment guidelines for that treatment. With that being said, there's a few here that are not just one treatment, but several. And physical therapy is a good example of that. So if I click on physical therapy, it's going to bring me to the treatment tab. It's going to show me all the treatments that go under physical therapy. Sorry, guys, I guess the webinar is slowing it down a little bit. Let's just see if I can refresh it. There we go. So you can see physical therapies here. Now, again, I could have just typed physical therapy in myself. This is just a bit of a shortcut. And it shows me all the different treatments that fall under physical therapy. So from here, I can either just scroll down and find what I'm looking for, or again, I can use my filter. So let's say I'm looking for physical therapy for a low back injury. Well, I start here. I just go to body system, click on low back, and now I can see the entries of physical therapy for the low back. In this case, there's two. There's one for group physical therapy and one for standard physical therapy. You'll also see some other matches, such as aquatic therapy, some of the other physical therapy modalities. If you're interested, and you can look at those as well. But for now, again, let's look at the physical therapy for low back. I'll go ahead and click on it. When I do that, it's going to what we call pin it to the top. It makes a little, you can see this little green box here with the title of the treatment in it. And that's going to give me the actual guidelines for physical therapy. And what I want to point out here is that all treatment guidelines have the same core components. At the core, they all have the treatment name, in this case, physical therapy. They all have the body system, in this case, low back. And they all have a recommendation statement. In this case, it's recommended. Now, in addition to those core components, a lot of guidelines will also have one or more other components, such as the criteria. This is commonly referred to as the patient selection criteria. Whenever you see a blue box, I always recommend paying close attention to it because it's usually where the sort of, if you will, meat and potatoes is. It's really where kind of the most of the information you're going to want is going to be housed in that blue box here. So in this case, for physical therapy for low back injury, what it does is it sort of delineates each low back injury, different types of injuries for the low back. And then below each type of injury, it gives you the actual guidelines. So again, in this case, it's 10 visits over 8 weeks for a lumbar sprain strain. If it's not specific lumbar sprain strain, it's 10 visits over 5 weeks. And you can see so on and so forth, depending on the type of condition that you're looking at treating. Now, in addition to that, you'll also notice that some of these, such as like a disc disorder, you can see there's other parameters here. Let's say it's not just a conservative treatment approach. Let's say you actually provided an injection. We'll provide some different recommendations for post-injection as opposed to different recommendations following different surgical procedures. And you can, of course, see them all here. So the key point to remember here when you're looking at these blue boxes is to make sure you're matching up the guidelines with the appropriate condition, because it can be very different depending on what you're treating. Lastly, below here, you'll see evidence summary. And again, this goes back to those 300,000 abstracts, 20-something thousand articles. This is those thousands of hours of research that we do every year to make sure we provide you with the most up-to-date evidence-based research for these treatment guidelines. So in this case, for physical therapy, here's the research that we've done. We've summarized it for you, especially for the physicians on the phone or the clinicians on the phone. It's always a good idea to take a look at this because this really provides a lot of the foundation for those recommendations. So it's not as simple as just giving you the recommendation frequency and duration, but it sort of gives you the why. This is really the why of the recommendation. And if you're ever curious before, if you wanted some more information on any particular part of the summary, you'll see that there's these little blue hyperlinks within the summary. And if you click on any one of them, it'll give you the citation. It will give you the ranking. It goes anywhere from a 1A to I believe it's a 10 or 11C. And in that methodology paper I showed you, it goes over the ranking, how we rank different studies. One is the most is the strongest supported, and I think 11 or whatever the highest number is the least supported. And then there's A, which is high quality, B is medium quality, and C is low quality. So in this case, this is a relatively strong study design, and it's very high quality. And lastly, if you want to see the actual abstract, if you click on the PubMed ID, it brings you out to the clearinghouse. This is, again, to the U.S. National Library of Medicine, and it'll actually show you the abstract of the study that was used for that part of the summary. Going back to the treatment guideline now. So again, this is for physical therapy. Next thing I wanted to show you was something a little bit more significant, if you will, and that's the spinal fusion. But instead of typing in spinal fusion, which I certainly could, I could just type in spinal fusion here, and it will give you those treatment guidelines for all spinal fusions. What I wanted to show you is you can also search for treatments by CPT code. Remember, though, just to make sure that CP is checked off here, go ahead and type in the CPT code. In this case, I'm going to use 22612. When I type in the CPT code, it's going to do a search. It's going to do a search. It's supposed to do a search. Again, sometimes when we're on these webinars, it kind of causes a little, there we go, causes a little slowness in the system. So again, it did a search for 22612. It tells me what the durations, it'll show me the durations for this procedure. And what I'm really looking for, though, again, is that treatment summary. So here's the treatment guidelines. It says right here, treatment. I'm going to go ahead and click on the CPT code below that. When I do that, remember, it's going to pin it to the top for me. And it's going to show me the treatment guideline, in this case, for lumbar spinal fusion. So again, there's the name of the treatment, corresponding body system. And some treatment summaries will also have these related topics. So if you look, these are different treatment summaries that go along with this type of treatment. So as we know, for spinal fusion, you could have adjacent segment disc disease. And these are different sort of things you may be curious in looking at when you're looking at something like a spinal fusion. Again, the recommendation statement, the selection criteria. So in this case, what would be needed to support, at least from a medical necessity standpoint, a lumbar fusion? Well, you need to have at least one of these. During the clinical presentation, when you're looking at the records, you'd want to see at least one of these. You'd want to see some of these. So you can see the different criteria that are needed to be evident in order for you to support this procedure as being medically necessary and appropriate. Whereas you don't want to see some of these conditions, because these would sort of be red flags and would sort of, I wouldn't say disqualify, but would cause concern in proceeding with a procedure like this, unless there's some sort of rationale to support it outside the guidelines. Which brings me to my next point. Again, these are guidelines. This is not a cookbook. You don't have to follow this recipe. It's not a rule. It's not written in stone. So for the providers on the call, the key is documentation. In my many years as a UR nurse, I can tell you 90% of the time that something was denied, it was usually due to lack of documentation. So it's so important. And I know everyone's so busy with their day-to-day work, especially the treatment providers out there. They got to see patients. They're being asked to do more with less. So I totally understand the challenges. But in the long run, taking a little extra time in the beginning to document everything in your records will really streamline the process and allow you to get approval that much quicker. Because believe it or not, and you may not believe it, but everyone is trying to approve treatment. Again, when I was a ER nurse, that was our goal. Approving treatment was so much faster and easier. And at the end of the day, our goal is to get someone back to work. And the only way you can do that is to give them treatment. They're not going to get better on their own. And again, the treatment has to be appropriate, though. So if you give them appropriate treatment, they get better quickly and they go back to work. And if it's appropriate treatment, by denying it at first, you're only going to have to pay for it in the long run. So it doesn't make any sense to deny treatment that's appropriate. What does make sense is to give them that treatment as quickly as possible. That's really our goal, is to streamline, to provide quality care quickly. We want to make sure that the patients get the right treatment at the right time as quickly as possible. So these guidelines just kind of help streamline that and allow people to allow folks to use our treatment guidelines to make those kind of decisions really quickly. The other thing, again, when you're looking at like a spinal fusion, you'll see that it's much more extensive. It's not as simple as just a physical therapy guideline. There's much more information within the criteria. So it gives you different indications, different things to look out for. Here in this case, you can also see some preoperative clearance options. You'll also see, especially in the surgery boxes, the corresponding hospital length of stay and the postoperative physical therapy. Now that physical therapy will basically just bring you, it'll pin to the top what we just looked at. So I'll just show you, like I click on physical therapy here. You'll see what it does. It just shows me the same guidelines we looked at before. The difference in this case, we'd be looking at the post-fusion or post-arthropathy guidelines. And then if I keep scrolling down back to the fusion one, right here, I can also see the hospital length of stay. Now, this is based on national HCUP data, so it's used by a lot of different carriers. And you'll see it gives you the recommended, the goal length of stay based on the type of procedure. So again, in this case, an anterior fusion, 3 days, posterior fusion, 3 days, laminectomy is 1 day. So you can see, like the physical therapy guidelines, what you're going to do is find the type of procedure being performed and then look at the best practice target regarding to hospital length of stay. Also keep in mind this is without any complications. This is if everything goes as planned, this would be the best practice target to shoot for. Okay, going back lastly for these for the spinal fusion, I find you know, a lot of times, again, when I do case management and you are, you know, sometimes things would be considered medically necessary. So they check the boxes, it meets the criteria, everything is good, but it doesn't always necessarily mean that's still the best next step. And so the treatment guidelines also provide some information around that, and that's that risk versus benefit. What I find is, especially if there's any case managers on the call, I find it's really important to go over this information with your injured workers. Make sure that they really can, you know, provide an informed decision. So if they know all the risk and all the benefits, it's medically necessary. Between them and their physicians, they've come to agreement to proceed with the surgery, then everything's great. But we all know a lot of times, especially with the spinal fusion, a lot of times when people go down that route, they've already had pain and decreased function for usually a prolonged period of time. They're willing to do just about anything to try to get better. And physicians, I'm sure you know this too, you know, sometimes patients, they don't hear everything you tell them, right? So they hear that, you know, what they do hear is, look, I've been in pain for a long time, I've not been able to work for a long time, and now I'm being told I can have the surgery and be better. Now, that may not be exactly what's told to them, but that's what they heard. So the challenge with that is they go ahead and have the spinal fusion procedure, and, you know, let's say they're in their 40s or maybe early 50s, and the challenge with that is we know that likely they're going to have, you know, again, that adjacent cementing disc disease. They're going to, you know, they're going to have some needs for additional surgery down the road. The chances that fusion really making a complete recovery, so they go from 10 out of 10 pain to 0 out of 10 pain, or, you know, complete restoration of function is really extremely low, if at all, right? It will provide benefit. Maybe they'll go from 10 out of 10 to 4 out of 10, or hopefully 2 or 1 out of 10, or, you know, perhaps they couldn't walk more than 50 feet before, and now they can walk 200 feet. Those are all great things, but they might, if their expectation was much greater, then we may end up with like a foul back syndrome, or we may have with some still negative thinking on the patient's part because they weren't really informed when they made that decision. So these guidelines, at the end of the day, what I'm trying to get at is these guidelines really can help provide the information needed to make some of these informed decisions for them. Okay, these are all the treatment guidelines. What I want to do now is show you the formulary, because the formulary is basically treatment guidelines for drugs. Now keep in mind, pretty much every drug in the formulary is available in the treatment guidelines. And you can get to them either by going to the formulary and searching for them and clicking on them, which I'll do in a second, or you can just search them in the treatment guidelines. Now there is some additional drugs in the treatment guidelines that are not in the formulary. And that's just because they're being used for sort of in a manner that's not approved by the FDA. So if you think of like ketamine, for instance, now, ketamine as a topical agent is in the formulary, but say it's an infusion, you'd have to come here. It's like you can see here, ketamine infusion. So if you're looking for actually treatment guidelines, what I recommend is using the formulary because you'll get some more information on it in the treatment guidelines as opposed to the formulary. So here's the evidence summary for ketamine infusion. You can see the different reasoning for the recommendation statement. Whereas if I now go to the formulary, and again, the formulary is just one of the tabs here, so you can just click on it. Type in ketamine here. You'll see this one is the topical form. It's not recommended. So with that being said, this is the formulary. You'll see the formulary is broken out into several columns. The first column being the drug class, the second being the generic name, the innovator brand. Now the innovator brand is the brand that brought the drug to market. So a drug may have more than one brand name. If you don't see the other brand name here, simply just go by the generic name because, again, we currently have the innovator brand. There's the note column, which we'll go back to in a second. Generic equivalent, yes or no. It's just kind of what it sounds like. Is there a generic available? The status, now this is kind of the foundation of the formulary. Y means there is evidence-based support that drug is recommended as a first-line option as being safe and effective. And N means essentially it's not recommended as a first-line option. So a lot of people think N means no. That's really not the case. It's not necessarily no. If you want to say anything, think of it as N means needs review, right? So if you want to use an N drug, it's okay as long as there's some sort of rationale to support using that medication over one of the Y medications. Because, again, the research out there shows that those N ones are not recommended as a first-line option. They're either not safe or as safe as the Y drugs, and certainly not as effective as the Y drug. So when looking at certain types of drugs, what you want to do is always try to go with the Y drug when possible. And if you have to go with an N drug, make sure there's some sort of rationale there to support, sort of justify using that medication outside of the evidence-based guideline. And then lastly is the cost. This is not, you'll see there's no Y and N has nothing to do with cost. This is just for cost modeling and setting reserve. That's the only reason there's even a cost there. Now, you'll see in a second, let's say that say you're a treating provider or you're out there, you want to prescribe a medication to one of your work comp patients. Let's say you want to prescribe them an NSAID. What we recommend doing is simply coming up here to the drug class box, clicking on NSAIDs. You'll see what it does then is it now just pulls out all the NSAIDs for me, and then simply sorting Y over N. And our thought process is you can choose any one of these Y drugs. All these Y drugs have support as a first-line option, whereas opposed to any of these N ones, which don't. The idea being you have so many Y medications available to choose from that there really shouldn't be any reason to need to choose an N1 generally. Again, there's exceptions to the rule, and in those cases you just document Y. But otherwise, you can see there's still plenty of choices from the Y drugs. And that's my purpose of this part of the demo, just to show you that for all these medications, there's at least one or more Y drugs to choose from. So you're never limited to any class of medication, meaning that in any class there's never just N drugs, so you can't really not prescribe something. I guess the only exception to that would be maybe the cannabinoids, although, yeah, there's a few, I guess, that only have N. But for the majority, the vast majority of all the drugs, you'll see that they always have at least one or more Y drugs to choose from to provide, again, the safest and most effective care for your patient. Now, with that being said, let's go back to that N drug. We were talking about the notes field I was going to go back to. That's that field here. Now, what the note field is, some drugs are used for more than one indication, and the note field will kind of tell you what indication that is. So a good example is Wellbutrin. Go ahead and type in Wellbutrin here. You can see it can be used for mental disorders or pain treatment. When it's being used for mental disorders, it's a Y drug. For pain treatment, it's an N drug. So again, that note will just refer to the status it's being referred to. And I know we're getting kind of short on time, but just real quick, when you look at, if you want to see the treatment guidelines for any one of these drugs, simply just click on the drug row. It'll expand it. It'll give you a summary of the treatment summary for you. It'll give you all the different formulations by NDC code that are covered under that entry. And then if it's a drug you're not familiar with or you want to share this with your patient, click on this Medline Plus link, and you can use this to either learn yourself about the drug if you're not a clinical person, or you can use this if you are a clinical person to share with your patient so that they can be informed on the medications they're taking. So it's a very good and valid resource to use as referential content. All right, so we don't have a lot of time, so I'm just going to real quickly show you some of the other things that we have, such as the duration guidelines. Duration guidelines are so important because it sets expectations early on. For instance, if I use a back sprain, what this is saying is that we're expecting them to be able to get back to some form of work within 10 days, though the claim average is 19 days. And we find there's several studies out there that show when you set expectations early on in the claim, they have a much higher propensity to return to work within those time frames. So setting expectations early on and understanding what those expectations should be is really important. The other thing is the longer you're out of work, the less likely you're going back to work. Again, there's several studies out there. There's one study that says something like if you're out of work more than 6 months, you have a 50% chance of never returning back to work. So all of our goal on this call is really to help patients, to help them to get better. And we know that if someone's out of work more than 6 months, and the fact that they have a 50% chance of never returning back to work, all the negative things that go along with that, the social interactions that they lose, the productivity that they lose, the hobbies they no longer do, the family relationship that they lose, those are all negative consequences or negative sequelae of not being able to return someone back to work. So it's so important. So ODG provides these duration guidelines to help. There's other ways, I'm not going to go into depth, but to really make it specific to what work they do. Let's say they do a heavy job. everything I change here is going to really update and change these values. You can see now at the 2718. So these are some of the products that ODG often has. These are disability duration guidelines. We also have a cost tab, which kind of gives, again, those cost projections or predicting costs for a particular claim. So you can see it's wage replacement, medical and other expenses, whether it be a claim typical or a best practice. You can see the difference in cost, moving them from that A value over to that B value. The TAO index, which stands for Treatment, Analyzer, and Outcomes. And that's the tool that really just looks at, given a condition, in this case back sprain, what are the most commonly performed treatments, breaks them down by frequency, lets you know the appropriateness, green, yellow, red, and black. So green and yellow are supported, red and black are not supported. And then what is the correlation to return to work? So a positive score, number 1 to 100, means there is a good return to work outcome, and a negative score, or 0 to negative 100, means there is not a good return to work outcome. Lastly is this job profile piece. So the job profile, part of getting someone back to work is understanding what they do for work, right? So let's say that this person is a firefighter. So I'll just type in firefighter in the job title. I'll click on it. What that does now is it tells me what a firefighter does. So it breaks it down, gives me by body system the different essential demands on that body system. If I click on any one of these, it'll show me the different demands of that body system. And at the very bottom, it gives me an aggregate of all the essential job functions for, in this case, a firefighter, breaks it down by physical demand and by frequency in an 8-hour work shift. It also provides me with the job description. And of course, I can customize any of this. And for the treating providers on the call, you may end up seeing some of these because what we recommend is any one of our users, maybe on the payer side, come in here, fill this out, and then send you this so that you can get a better understanding when you're making those kind of decisions about whether someone can or can't do that particular job. So if you see that, you'll see that we can print, we can share it. You might see this as a provider. And then lastly, the one thing I didn't show you, and I know we've got time for questions just real quick, because I think it's really important, is the MED calculator. Again, that's in the formulary tab. So again, we understand the higher dose of opioids, the higher the risk. So we have this MED calculator. For those of you who are unaware, MED stands for morphine equivalent dose. So it's just a way for us to compare apples to apples, being that every opioid has a different potency. We want to first convert them to the MEDs. So for instance, hydrocodone is 1-to-1. So if I type in 30 milligrams of hydrocodone, it's 30 MEDs. Oxycodone is 1.5-to-1, so 30 would be 45. So you can see what it does is it converts the daily dose of each medication to its MEDs, and then adds up the total for the day. And it gives you this color with this scale right here that basically tells you based on the total number of MEDs, what is the associated risk. So whether you're a treating provider and you're trying to get an idea based on the dose that you're prescribing, what the risk is associated with that dose, or if you're on the payer side, you're a case manager or a claims adjuster, and you're trying to determine the risk so you can have appropriate conversations with that treating provider, you can also use this tool as a way to start that conversation. So with that said, I know it's a lot of information. Is there anyone have any questions or any feedback that we can help address?
All right. Thanks a lot, Jamie and Jacqueline. We are getting some questions coming in. It looks like we may only have time for a couple. So I'll start with one and see where we go. When a claim is closed under Arizona Workers' Compensation System, oftentimes a supportive care may be awarded. Should ODG be used for supportive care awards, and if so, how do I use ODG for supportive care?
Well, this is Jackie, and I'll take the first part of that, and then I'll pass it on to Jamie. But as it pertains to the management of chronic pain and the use of opioids for all stages of pain management, ODG applies to medical care or services included in supportive care awards on or after October 1, 2016. As of October 1, 2018, ODG applies to all other medical treatment or services included in supportive care awards. So, Jamie, if you want to talk about where people might find maintenance, for supportive care recommendations.
Absolutely. So I think that's a great point. So at the end of the day, supportive care, again, just means we're providing some sort of treatment as a future sort of medical treatment. With that being said, supportive care in and of itself doesn't mean necessarily that all treatment is appropriate. It just means if you have an exacerbation or some sort of need for additional treatment, provided the treatment is medically necessary, then it would be supportive of a supportive care award. So that being said, medical necessity is the key word. So ODG would work the same exact way. and that if you wanted to provide a treatment under supportive care, you would still determine if it's medically necessary. So whether it be, let's say it's an epidural steroid injection. Let's say they've had it before, and under supportive care they would need to have some more. Well, then you would just, I'm going to type it in here. You would just do a search for that particular treatment, again, to determine the medical necessity of it. So in this case, if it's an epidural, I can click on epidural steroid injections, and it will tell me what criteria is needed. Again, it says the condition recommended, and over the blue box, it tells me the criteria is needed to support additional treatment. So say you had some treatments before you hit the supportive care, and it provided good relief. Perhaps you had 60% pain relief. Now you're a year later, and under supportive care, you want to do additional epidural steroid injections. Again, come to ODG, look at the epidural steroid injection criteria, and here you can see, provided these are all met, provided there is truly a radicular component, and the previous injections provided at least 50% pain relief, then you can do up to 4 regions per year, 4 blocks per year. So when you're looking at supportive care, again, it's no different than acute or subacute care. At the end of the day, you want to determine the medical necessity of any given treatment.
Okay, and I want to add one more thing. This is Jackie again. When I reference supportive care awards, any supportive care awards that have gone through litigation and have been issued through a hearing decision or through a compromise in settlement are not subject to this. You would have to go back through the Administrative Law Judge Division to change any supportive care that has been awarded through a hearing decision or through a compromise in settlement.
Okay, great. Well, thank you both. I think we're going to have to cut off the questions now because we do need to end at the top of the hour, and I want to be sure that we can give the contact information. Jamie, if you could put it on the last slide or kick it back to my screen, I can get it to there. There we go. So thank you everyone for your attendance. We will be sure to email you if you have typed in a question. We will get back to you. And also the webinar is being recorded, and the recording will be sent to you, and I think we'll be able to include those slides too. I know a lot of you like the slides. So it was a great presentation. Please get in touch with us at odghelp@mcg.com or 1-800-488-5548 if you have questions about ODG. And of course, you can also get in touch with Jackie if you have more regulatory questions. And thank you, Jackie and Jamie, and thank you all for your attendance. Have a great day.
Thank you.
Thanks, guys.